We're very fortunate to have 3 faculty members from Emory School of Nursing as panel presenters today. Dr. Nicole Carlson conducts research on the biologic mechanisms of labor dysfunction and strategies for achieving optimal perinatal outcomes and decreasing racial disparities in women with different levels of obesity. Dr. Madeline Hauser brings to her current role at Emory a decade of extensive research experience on the bench and a doctorate in immunology. Her passion is to apply the power of computational research tools to gain new insights from big data sets that can lead to improvements in human health. Dr. Nicholas Giordano's research focuses on characterizing biopsychosocial symptom trajectories that can be utilized to stratify individuals at risk for experiencing poor health outcomes and to inform the timely delivery of targeted interventions. Dr. Giordano is also a pilot investigator within our center with a study titled Symptom Trajectories and Inflammatory Markers among patients with co-occurring obstructive sleep apnea and prediabetes. Drs. Carlson and Hauser both support our P30 investigators as members of the Administrative Core and the Data Science Core, respectively. Today, they will speak to us on their reflections on incorporating social determinants of health into omics research. Please join me in welcoming Drs. Carlson, Giordano, and Hauser.
Well, thank you everyone for this opportunity to share with you some of our experiences. And I'm Nick Giordano. I'm an assistant professor here at Emory, and I'm joined by my colleagues, Dr. Hauser and Dr. Carlson. And we just wanted to share some of our reflections on incorporating social determinants of health into omics research. Before we begin, I want to say that myself and fellow presenters have no conflicts of interest to disclose, but we would like to recognize the funding of this work in part from the NIH, specifically NINR, which funds the P30 Center, which we're all investigators in here. Of course, it's so important that we recognize not only the leadership of the P30, but also those who organize this great conference, including Dr. Yang and Dr. Holstead, our co-investigators and research staff that make our studies possible, as well as the participants who give so much of their time and data to our science. So this is just a brief overview of today's presentation and to orient everyone on what to expect. My colleagues and I will first provide some context on our reflections in the larger landscape of SDOH work occurring at this moment across disciplines and settings. This includes thinking about how social determinants of health are defined and the impacts they have on health and society, as well as ongoing efforts to enhance data capturing to guide research in this space. We have a series of really wonderful case studies from our own research to share with you all that really outline some of the challenges and successes we've had in incorporating these metrics of social determinants of health into omics research. And before that, we'll take a deep dive into the nitty-gritty of what it looks like leveraging social determinants of health data in larger analyses with high throughput variables. And again, come back to some really interesting case studies utilizing these metrics. But first, really want to think about how social determinants of health is an amalgamation of factors that collectively influence health outcomes for all individuals based on the environments in which they're born and grow in and continue to live in, as well as their interactions with others, as well as the systems of health and government agencies across our lifespan. As you can see here, the federal government has classified social determinants of health into these neat yet not always mutually exclusive domains of education, health, neighborhood and environment, social and community, as well as economics, access, and quality to all of these services. And these factors are not new. Researchers have been studying components of social determinants of health for decades, and yet just now, largely due to the pandemic, social determinants of health are being thrust into the mainstream with substantial funding from agencies to accelerate this trend for us in the research space. And it's because of this momentum that myself, as an early stage investigator, wanted to put in the work to understand how to optimally study social determinants of health, and not, as others have coined, become a health equity tourist, but to really capture rich data that can inform future innovative questions in my program of research. And so these are our reflections are just meant to be that, my own experiences growing as a nurse scientist, interested in learning how to optimize data capturing to inform rigorous programs of research that advance health of individuals across the lifespan. And so I just wanted to give you guys that context as we walk through this first half of the presentation and into my colleagues' work. A great example that's commonly used is really focused on an individual's neighborhood and their access to fresh foods when we think about social determinants of health. This is often an oversimplified approach that highlights a somewhat linear relationship between availability of grocery stores that carry fresh, healthy foods and the lifetime risk for developing multiple chronic conditions, which is really the focus of our NINR funded P30 Center here at Emory. However, this relationship between food availability and development of chronic conditions, and ultimately even lower life expectancy, is much more complicated than a simple availability of grocery stores. For example, we know that the intergenerational consequences of racism and racist policies around redlining and financing have resulted in limited development of shopping districts with large grocery chains and really accessible transportation to those grocery stores in these communities. And so what we're seeing is happening pretty much in predominantly communities of color, where there's this inavailability of fresh groceries, but that's not really enough of the equation, right? When we think about it, having access to food doesn't necessarily change behavior. We can't just start dropping in grocery stores into communities, given the potentially prohibitive costs of food, time to store and prepare and cook fresh foods. And then ultimately, for the reasons of this presentation, we have to also think about the omics perspective. Lifetime diet ultimately can impact our gut distribution and microbiome, which on top of prolonged stress can create an increased presence of bacteria that are linked to a number of chronic diseases, specifically things like insulin resistance that ultimately lead to the development of diabetes. And so given the multifaceted impact of place, behavior, and social connectedness on chronic conditions, you can begin to see the importance capturing social determinants of health has for folks such as myself conducting pilot research in the P30 here at Emory, really focused on chronic multiple morbidities. And again, this is just one example looking at access to foods, diet, and ultimately how that can present in the gut microbiome. But there's a number of other examples when we think about social determinants of health, and one of the most important, obviously, being at this time COVID-19. We know that barriers to employment, familial wealth accumulation, and education have contributed to disproportionately larger number of people of color holding essential occupations that carry higher risk for exposure to COVID-19, and ultimately they bear a higher burden of the disease compared to other ethnic groups and racial groups. We know that social distancing measures can pose huge challenges for individuals living in congregate settings with disabilities or those who are in crowded households that can't socially isolate if and when they become exposed to COVID-19. And of course, we can think about other factors of social determinants of health, such as individuals living with other conditions such as substance use disorder, who may be experiencing increased isolation and barriers to treatment, resulting in ultimately increased risk for overdose if they're utilizing substances in isolation as opposed to in community settings. And so these just kind of all come together to highlight that social determinants of health, whether it's based off of traditional socio-demographic factors that we're used to collecting as researchers around race and ethnicity and age, or if it's more about the context in which where we live and who we interact with that ultimately can drive health outcomes. And so accumulation of decades of research in the space of health equity, paired with the massive disruptions COVID-19 has caused to our daily lives, we've really seen this exacerbation in the inequities across communities nationwide. And this moment of recognition from private and federal funding agencies to support high quality science to really understand how social determinants of health are not only impacting health outcomes, but then what interventions can be developed to really act on those to change trajectories of individuals across the lifespan. For example, I show you here NINR's newest strategic plan, which really commits 2 of their 5 priority areas or research lenses to these related spaces with an emphasis on supporting research that can improve quality of life across a number of social determinants of health-related factors. And so this is all wonderful to think about capturing and moving the needle forward by really studying social determinants of health, but it creates a real barrier for us as researchers when we recognize that social determinants of health has really become a catch-all for any factor outside the health system that really is correlated with health. It's this broad definition, with opaque approaches to measurement. And given how multifactorial social determinants of health are, it's really important to apply this intersectionality lens to our programs of research, but that requires having well-structured data capable of capturing these various domains and constructs to then model for our outcomes. And so here in the center, we've committed a lot of our energy in trying to categorize and think about what are key or core domains that are related to social determinants of health. And you can see here, we've adapted Um, Several approaches put forth by Healthy People 2030, as well as the Centers for Medicaid and Medicare. But really, it's a number of buckets that are not mutually exclusive, that kind of bleed over one another, uh, but ultimately provide us a way in which to group and structure through our center how we approach the science we need to conduct to really move the needle on social determinants of health as far as impacting chronic comorbidities. And so while these are all wonderful to have, it's really difficult to capture every component of health that really contributes to outcomes. And so I wanted to walk everybody through some of the other metrics that are out there that may or may not be interest to you as a researcher. Um, First is these clinical tools. Social determinants of health have been obviously a priority for clinicians engaging with patients, especially those who are working in primary care outpatient settings. A few organizations in these spaces have put forward clinical screening tools for capturing potential social determinants of health that contribute to poor outcomes, including the National Association of Community Health Centers, the American Academy of Family Physicians, and even the Centers for Medicaid and Medicare Services. Yet, as you can see, they vary in length, these clinical screening tools, and typically capture just the presence, yes, no, or absence of conditions and not really severity, as well as huge discrepancies in which domains they're actually capturing. No one tool can succinctly capture every component of health or social determinants that contribute to health, but these are great tools to build upon in clinical settings to support data capturing and health records for future research that leads to real practice changes and ultimately improve outcomes if we can capture them systematically across patient populations and then leverage those for really informative research questions. But that's difficult in and of itself, given how constrained clinical practice settings are, that is to say, with their time and what they can actually get done and assess with a patient in front of them. But then on the other end of the spectrum is the research component. From this perspective, there are a number of tools available to enhance data collection, and here I've just highlighted two from the NIH. This first one is an social determinants of health specific common data element, or CDE, put forth by NINR CDRNS, or Common Data Repository for Nursing Science, that includes a number of validated measures within it to form a 30-item questionnaire for participants to complete related to social determinants of health, and that includes things like psychological distress, as well as financial security, food security, and safety in their community. But again, this is 30 items, not really as robust as having a battery of measures that we'd love to have as researchers that can capture a range of components. And that's what's exciting about this other tool, called Phoenix. It's supported by NIMHD and contains a battery of validated measures related to 16 domains of social determinants of health, as well as additional measures for capturing individual level components that contribute to health, such as perceived discrimination, and even societal level factors such as air quality. And so within the Phoenix toolkit, there's, I would say, dozens of batteries of measures that all include their individual validated instruments and tools to help capture these components. And these serve as examples of how to capture rich, high quality, well-structured data around social determinants of health. But again, the limitation with this being they're time-consuming research measures that require research personnel to administer many of them. And so these examples, whether clinical or in research, are really meant to illustrate that social determinants of health data comes in a variety of forms that can ultimately be utilized to answer novel research questions aimed at understanding how our environment and our way of living and our interactions with others ultimately contribute to our health outcomes. And so with that, I'm going to hand it over to my colleague, Dr. Carlson, to walk you through an exemplar case study with some of these social determinants of health data. Dr. Carlson.
So we were really excited to see that we had collection of racism across these small studies, because in here I'm borrowing a slide that was presented by, you can see the name of the researcher at the Cannes conference, Dr. Rodriguez at the Cannes conference back in September of 2021. And she made the point that when we're talking about the social determinants of health, it's important that we remember that the determinant of the determinants is structural racism. Unfortunately, in a lot of data sets, when you're looking at the social determinants of health, things that measure racism or perceived discrimination, anything really like that, is not very well captured. Sometimes you can get this at the neighborhood level, as Nick was referring to. But we did have that in this data set, so that was part of what we were able to build. So a little step off, and I'm building on what Nick has already said a little bit, but I just want to really drive home that what high throughput methods can tell us and what they cannot. So what they can tell us, they describe the exposome, which is the totality of human environmental exposures across that person's lifetime. And it also can tell us, when we look at high throughput methods, how these exposures relate to a person's health and etiologies of how the social determinants of health can influence health. So all those things are really exciting, I think, about this work. But it's important to remember what they're not. And what they're not is a way of biologically defining people by their race, ethnicity, sexual orientation, etc. In fact, these factors are political or social constructs that are fluid across time and geographic area. And because they're linked to social hierarchy in different communities, they predict the way that people are treated differently in that community. So our omics can help us to see this differential treatment. So one of the first steps after we figured out in the P30 study what social determinants of health variables we had access to was to then conceive of how did we think that they were influencing our main outcomes. And in the case of the P30, you can see the main outcomes here on the right in this theoretical model that we came up with. So the symptoms of fatigue, anxiety, pain, and depression, you can see that the way we conceived of this was that chronic conditions would flow through race-related stress, which is our proxy for racism, structural racism, which would then affect as a determinant of the determinants, the social determinants of health. And you can see they're listed in the orange box, the things that we had access to, which would then flow through to behaviors similar to what Nick was talking about in his exemplar. And that what we were hoping is that we'd be able to see that reflected in the metabolites and the metabolic pathways, also in the microbiome outcomes that would affect the symptoms. And so this analysis is still ongoing, but I think what we demonstrated with it is that we had some challenges in this, and in a minute, Dr. Hauser is going to go over some of those. I'll give you a sneak peek that one of the big challenges was that in this P30 umbrella, not all studies collected the same questionnaire data from all participants. There were differing rates of missingness by sub-study, so dealing with that was a big part of this. But there was this opportunity, and that was to characterize metabolites and metabolic pathways, or this internal environment, and see if there were differences across people with exposure to variations in the social determinants of health. So here I'll turn it over to Dr. Hauser to talk about incorporating social determinants of health in omics data analysis.
Thank you so much. My name is Madeline Hauser, and I am delighted to participate in this panel today. In my current position in the School of Nursing, I work with a number of investigators to provide analytical support for their existing projects, particularly those involving omics. So how to incorporate social determinants of health into a larger analysis strategy is something that I think about often. So for my contribution to this panel, I'll briefly highlight some of the challenges that I've encountered with that and some of the approaches that I think can be useful for addressing it. Dr. Carlson already alluded to one analytical challenge demonstrated by our P30 projects, a lack of consistency in the data collected and the instruments used. And this can complicate analysis plans and make cross-study comparisons difficult, or at least more limited. I'll show you one specific example with data on participants' health insurance. So out of the 7 total projects that fall under the umbrella of the P30, 4 did not collect any information about participants' health insurance. 2 projects asked participants to identify which type of health insurance they had out of a total of 4 choices. And 1 project first asked about health insurance as a binary variable, so yes, no, do you have health insurance? And then also asked participants to identify their health insurance type out of 7 choices. So you can see that a situation like this can make it difficult to include information about health insurance in any cross-study analysis of our P30 projects. Another common challenge I'll mention is data quality. And data quality issues are certainly not specific to omics data or data on social determinants of health, but I include this because there can be problems with data quality or missingness that are more prevalent in studies involving disadvantaged groups, in which many individuals may have relatively lower health literacy or education level. A couple of examples that I've encountered of this include an instance in which some study participants did not understand that a particular survey question was asking for monthly income rather than annual income, which resulted in a very odd distribution for values for that variable. And in another case, an unlikely number of participants reported experiencing a heat stroke in the past, which is a potentially life-threatening, very serious condition. And most likely, at least some of these participants were confusing heat stroke with other less severe manifestations of heat-related illness. So these kinds of situations can leave you with some unreliable data and some variables that really can't be included in your analysis. So it's something to watch out for. And getting into even more complicated challenges. As you heard from Dr. Giordano earlier, examining the impact of social determinants of health can entail collection of a lot of data. And when you get to the analysis stage, that presents the challenge of figuring out how to incorporate those data meaningfully. So do you try to include as many social determinants of health variables as possible? If so, among other things, you have to keep in mind that many of the measures are correlated with one another, which can present a statistical challenge. Or do you try to narrow the list of social determinants of health to only the ones that are most directly relevant to the particular study that you're working on? That could be challenging to do empirically, especially for omics studies. And if you're selecting variables a priori, it definitely requires some thought. So, which of these 30 variables most accurately captures the particular aspect of poverty that is most relevant for your study population? So, it's a challenge. And that variable selection process may be further complicated by consideration of how selected variables will be used in the analysis. For instance, if you want to include multiple separate social determinants of health variables, you may find that you're limited in that approach by the total sample size. Obtaining omics data, or even multi-omics data, is quite expensive. And that often means that we're comparing levels of thousands of features in tens of samples before any additional variables are considered. So many omics studies just may not be powered to adjust for multiple social determinants of health measures. And I say adjust, but that raises the important point about how social determinants of health variables are treated in analysis. A common approach would be to treat them as covariates or confounders, and to, as much as possible, account for their effect in a model. And this may be appropriate in some cases, but not so much in others. And it does take the stance of trying to control for the impacts of social determinants of health rather than to examine them directly, which may be problematic from a translational perspective. Also, tools for multi-omics integration may not necessarily have straightforward mechanisms built in for covariate adjustment. So how do we deal with these challenges and integrate social determinants of health into omics data analysis? I can't tell you the answer because the field hasn't decided on the answer yet, hasn't identified one optimal solution to this complex situation. But with that disclaimer, I'll talk about a few potential approaches. First off, as I was suggesting, some traditional strategies for handling confounders or covariates aren't as effective in analysis of omics data or particularly well suited to handling social determinants of health. A typical omics analysis workflow involves comparing the abundance of all features, whether those are the intensity of small molecules or DNA or RNA reads, comparing all features based on a single variable of interest, with or without adjusting for confounders or covariates, and then correcting for multiple hypothesis testing. So you can readily see how the inclusion of several covariates in combination with multiple comparison correction could easily surpass the power of small-scale omics studies. And the covariate adjustment is often through some kind of regression model. And that comes with assumptions of linear relationships between predictors and dependent variables, absence of collinearity among the covariates, things that don't necessarily apply to social determinants of health. So some other common approaches to examine contributing variables, such as stepwise regression or mediation analysis, suffer from some of these same drawbacks as they often involve regression, and they're often challenging to scale for high-dimensional omics data. So one approach to get around some of the complexities related to omics data is to use existing omics analysis methods to reduce the dimensionality of the data prior to trying to integrate social determinants of health. This could mean identifying features significantly related to your variable of interest by itself, and then examining associations between social determinants of health measures and those selected features. Principal component or partial least squares discriminant analysis could also be used to identify a subset of features for further analysis. Of course, this approach doesn't fix some of the other issues that we've talked about with social determinants of health measures. So I propose that if we want to find better options for social determinants of health and omics analysis, we're going to need nursing researchers to put their heads together with statisticians, bioinformaticians, etc., to develop more sophisticated techniques that can handle the complexities of social determinants of health and omics data. For instance, in a moment, Dr. Carlson will tell you about a study in which she used latent class analysis to identify different groupings within a data set and then relate those groups to social determinants of health measures. I think a similar approach could be useful in omics data with some kind of clustering, network, class analysis, identifying patterns in omics data, which could be then linked to characteristics of study participants. Also, machine learning models that could take both omics data and social determinants of health measures as input could identify factors among those data that best predict particular outcomes. So there's a lot of work to do in this space, a lot that still needs to be developed and optimized, and I look forward to seeing what emerges in the near future. And with that, I will let you hear from Dr. Carlson about some examples of different approaches that could potentially be useful in this and that could be applied to omics.
Thanks so much, Dr. Hauser. So let's go through the last two of our case studies. You've heard the case study number one, which obviously had some problems. And so case study number two was a little bit more straightforward. And in this, we were talking about a secondary analysis of social determinants of health. And this was in a study that had a standardized collection of social determinants of health measures. So the secondary analysis that we performed was on the New Moms-to-Be Nulliparous Pregnancy Outcomes Study. Monitoring Mothers-to-Be was the full name. This was an NICHD-funded multi-site prospective cohort study. And they enrolled a little over 10,000 people having their first baby who were racially, ethnically, and geographically diverse. You can see more information there about their primary outcomes. They did this longitudinally, and they had a lot of self-report questionnaires, body composition measurements, and biologic samples and chart data. So as a nurse midwife, this was gold, and to make it even better, this data set was free. So we were able to get a hold of it, and what we found when we got in there was that it was very rich in the social determinants of health variables. Also, and this was really intriguing, thinking back to what we were talking about before in terms of structural racism being the determinant of determinants, in this data set, they include race of participants from 3 different perspectives. So first they asked people about their ancestry. Then they asked people about what race or ethnicity they self-identified as. And then finally they asked people what race or ethnicity did other people in the United States most often identify them to be. And it was this last variable that we used to be a stand-in for racism. They also, this data set though, included perceived discrimination. It also had information about the primary outcomes we were interested in, which were labor processes and outcomes, limitations of this analysis, and this is true in a lot of the data sets that you might be able to get access to. The investigators did not include neighborhood level information, so they, in the effort to make this de-identified, we could not get a hold of the zip code or the census tract of the participants. And so that really limited our ability to look at some of these structural social determinants of health. And so similar to the last analysis that I talked to you about, I think a really important piece of this analysis is to come up with that theoretical model and to really think about how do we perceive in this that the social determinants of health are related to the other variables leading up to our outcome. So you can see our outcome in this particular study was a maternal morbidity event. And then, but we conceived of the social determinants of health as in the blue box. This is all of the social determinants of health that we were able to access in this data, that we really conceived that they flowed through to the way that the behaviors people had during pregnancy, the conditions that they developed or didn't develop, and their labor and birth characteristics to increase or decrease their risk for this postpartum maternal morbidity event. So of course the question was, how do we pull together all of these social determinants of health to make this analysis something, even though we had a large sample size, still there was the question of how do we do this? And what we did was something that Dr. Hauser talked about with reducing dimensionality reduction. We use latent class analysis on the social determinants of health. So when we did that, we came up with 6 groups. So here in this slide, I'm showing you those 6 groups across the bottom. And what you see above the numbers there are descriptions of those groups according to some of the social determinants of health that we use to create those groups. So there's a lot going on in this slide, but I'll draw your attention to group 4. Group 4 there in the middle of your screen, you can see just at a glance that it has the highest levels of the blue color, the solid blue color behind it. That solid blue color has to do with the income, household income, which was the highest in this group compared to the other groups. Also at a glance, you can see that in group 4, it had the lowest levels. A lot of the lines that are going through there, those lines refer to experiences of discrimination, how well people spoke English. They spoke English very well in this group. It also had to do with their attainment of professional graduate school. This was the highest educated group. By contrast, if you track over to group 2, you can see that it looks very different at a glance. One of the ways this group was different was that this was the highest percent in this group of people who had reported speaking English less than very well. This group also had the highest levels of people who were more recently immigrated to the United States. And then the last group that I'll draw your attention to is group 6 on the far right, and you can see also looks very different than the other groups. In this group, we had the lowest income levels, and at the same time, we had the lowest educational attainment and the highest stress levels. So already you can see that using latent class analysis, we were able to take 14 different social determinants of health variables and return these groups of people that were very different from one another. Here's how race and ethnicity distributed across these groups. So again, going back to group 4 in the middle, you can remember that was the group that had the highest levels of income, the highest levels of education, the lowest stress. You can see 94% of the people in this group were presenting race was white. By contrast, the group 2, which was the group of people that spoke English less well, and when we're recently coming to this country, you can see that that group was 58% Hispanic presenting, and 24% white presenting, 19% is black presenting, Asian presenting. And then going over to group 6, that was the group that had the lowest ages. You can see it was kind of split amongst the groups in terms of Hispanic, black, and white presenting. And so what I think, the reason I brought that last case study to your attention was, although we didn't use omics in that particular analysis, you can see how by using that dimensionality reduction on the social determinants of health, we were able to really describe those groups, which then could have been used to look at any kind of omics if we had looked at it. And then finally, a case study number 3, and this one is kind of the most optimum situation for trying to do social determinants of health analysis, and that is in a prospective cohort study where we're going to be integrating the social determinants of health and lipidomics. And this study is not completed yet, so I can't show you final results, but it is in year 1. This is an RO1 investigation that my team is working on right now. So a little background, I'm sure plenty of you, even outside of pregnancy, understand and have heard that maternal labor outcomes, we have a really terrible disparity by race in outcomes. So we see that non-Hispanic black women are 3 to 4 times more likely to die of pregnancy complications compared to white women. They're also 2 times more likely to end labor with a cesarean birth compared to white women. And specifically when their labor is induced, in other words, kind of made to happen artificially, they're 3 times more likely to end their labor with a cesarean compared to white women. So a lot of this, we really don't understand why it's happening. There's a lot of theories for it. But a lot of my research is trying to look at how do we prevent unplanned cesarean birth. And so some preliminary data that we had, we were looking at people. This is a little very simple pictograph of what labor looks like. So you can see on the timeline is cervical dilation, and in a typical labor for a vaginal birth, people go from 0 centimeters dilated to 10 centimeters dilated and then are able to push and have a baby. And so in this preliminary data, what we did was we looked at the different parts of a labor induction, and we were able to locate some comparison groups. Comparison groups are often something we use in omics analyses. It allows us to take whatever the outcome is and have very different groups in terms of that outcome that we can then hopefully pick up that omic signature that differentiates them more easily. So we were able to describe 2 groups. In the control group, there was they had a pretty quick labor. In the cases with their labor, especially during this green part of active dilation, took nearly twice as long as in the other groups, and it required a lot more medicine to get them to 10 centimeters. And when we did metabolomics with these samples that we collected during the 3rd trimester of these people's pregnancy, what we found as the pathway that differentiated the cases and controls that we were looking at was, you can see here at the top, linoleate metabolism. For those of you who aren't familiar with that, that has to do with the polyunsaturated fatty acids and how the body is breaking down fats. And so from that preliminary data, we brought together a theoretical idea that that something about the levels of PUFAs in people's bodies was changing how their labors went, whereby lower levels of certain essential PUFAs was making people's labors much, much longer and making it more likely that they would end with a cesarean. And so I bring you now to this slide to show you how incorporating the social determinants of health is so important in the way that we conceive of these questions. So if you look to the left, this is kind of a way of conceiving the problem of a labor dysfunction that is without the social determinants of health. And I would add is wrong. So we could think first, well, so black women have higher levels of C-section compared to white women. Well, one way of looking at this problem is that they are twice as likely to be obese during pregnancy as white women, which is true, according to BMI, and that black women are more likely to consume diets characterized by low fiber and high fat content, which is true in the United States. and that Black women therefore are also less likely to engage in regular physical activity during pregnancy, which is true on average in the United States compared to white women. And that therefore means that Black women are more sensitive to metabolic dysregulation and then have these changes in their diet and physical activity, which makes them more at risk for these problems during labor. A better way, and I want you to try to pay attention as I'm going through this, where we're incorporating social terms of health and the determinant of the determinant racism, Black people are more likely to have high levels of perceived stress, perinatal depression, and anxiety compared to white people. This stressful daily living leads to less healthy eating, physical activity, and more pregnancy complications. Neighborhood safety and support for exercise is lower amongst Black compared to white women in the United States. That's true. Early life trauma has been known to predict healthy behaviors and actually change physiology so that whatever the behavior is, it has a different influence on the body. And racism increases stress, inflammation, and decreases the quality of prenatal and intrapartum care. And so this better way of looking at it, you can see at a glance, there were a lot of social determinants of health that we really wanted to target in trying to answer the question of what's going on. So that brought us to this prospective cohort study called The Weight of It All, Balancing the Scales for Pregnancy and Birth. And we specifically focused this work in Black women. And so our study is a 5-year investigation. We're looking to longitudinally follow through pregnancy 150 participants being cared for at Atlanta Birth Center. And we are using a community-based participatory methodology. Those of you who haven't heard of that, I think another essential piece of collecting the social determinants of health is to interface with your community so that you understand and are informed by them as to what social determinants of health are important for this problem. And so after we met with our community and looking at our theoretical model, what we came up with were the social determinants of health selected for this study. So you can see neighborhood level factors. We looked at health literacy and housing security. We also looked at stress, which was something we conceived to be really important, and discrimination experiences, neighborhood safety. We looked at resilience. We also looked at anxiety, depression, transportation options, social support, and adverse childhood experiences, or ACEs scores. And so in analysis planning for this is kind of what we're thinking to do. So once we collect the data from people, first, obviously, we're going to describe our primary outcome, which is labor dysfunction. We're going to do that in multiple ways. And we're going to create groups of people according to whether or not they experience that outcome or not, and what degree of that outcome did they experience. We're going to rank participants by their degree of labor dysfunction. So, for example, we're going to look at the duration of labor and try to pick out groups of people that had the slowest labors versus the fastest labors. That's one thing we're planning to look at. We're going to evaluate associations within those groups and on discontinuous variables with lipids and lipid pathways to try to get an idea about what lipids are associating with these labor difficulties. Then we're going to planning to use a dimension reduction technique similar to the one I showed you earlier to bring together groups that describe these social determinants of health variables. And we're going to evaluate labor outcomes by those social determinants of health groups as well. And then finally, we're planning to evaluate lipid and lipid pathways by social determinants of health group and comparing to see which ones of these lipids and lipid pathways that were associated with social determinants of health group were also associated with labor dysfunction. We're also going to explore some of the other machine learning and other types of things that you heard about from Dr. Hauser, but it's more than we could go into now. So to conclude, I'm just collected a few things that we'd like for you to take away from this talk. First, obviously the social determinants of health are critically important descriptions of people's lived circumstances. They're critical for researchers who are seeking to understand how to optimize health. Just because few researchers were doing this work in the past doesn't mean that we shouldn't all understand that we really need to be doing this work now. When we combine social determinants of health with omics, we have the potential to reveal etiologies by which a person's lived experience manifests in their body and changes their health. Obviously, that giving us ideas for ways that we can hopefully intervene and help them to have optimal health. Challenges exist. Some of those we've gone through today, and there's many others we haven't described. Selecting social determinants of health for your study, Thinking about participant burden, how many social determinants of health measurements am I going to ask this person to fill out? Analysis with multiple social determinants of health and how to capture that information, especially in limited sample size. How to consider social determinants of health when you're already doing a complicated omic analysis. But we've also offered a couple of solutions to these problems and showed you how we're testing others. For example, mixed methods or community participatory research methods to be able to understand which social determinants of health to choose and understand maybe how those social determinants might be influencing health. Theoretical models to guide your social determinants of health selection, dimensionality reduction, machine learning, other types of analysis methods to try to take those social determinants of health and help to put them together with our omics and get some good outcomes from it. And so with that, we'll conclude. We thank you so much for your attention today, and we look forward to your questions.